Assalamualaikum and greetings everyone. I'm Mardia Apika binti Nazaruddin and I'm from Group 6. We are going to present an article titled Effects of Housing Value and Medical Subsidy on Treatment and Outcomes of Breast Cancer Patients in Singapore, a retrospective cohort study. So, in this video, we will touch about the introduction, the authors, method, including study design, outcomes, statistical methods, and the result. And then, we also present about the discussion and the conclusions of the overall article. I would like to introduce my group members, which is Cho Lejun and Muhammad Zarif bin Zainal.
Breast cancer remains a significant public health concern globally, demanding continual exploration into factors influencing its treatment and outcome. Now, we are going to discuss an article investigating the effect of housing value and the medical subsidy on treatment and outcome of breast cancer patients in Singapore. This retrospective cohort study aims to assess whether housing value as a proxy for socioeconomic status influences breast cancer patient presentation, treatment choice, compliance, and outcome. Secondly, to investigate the effect of enhanced subsidy on patient receipt of treatment and survival. The housing value index is chosen to be a surrogate measure of socioeconomic status. The common approach, such as income, education, and employer status, are not suitable to be chosen as measurement of the socioeconomic status because a large portion of the older breast cancer patients are in the traditional role of an unremunerated homemaker. Since 79% of residents live in the public housing under tiered subsidy scheme, therefore housing value provides a good surrogate measurement of the socioeconomic status. The author of this article are made by a team with diverse expertise ranging from clinical oncology to biostatic and research. Fong Yong Wong, senior consultant radiation oncologist with 21 years of experience under the National Cancer Centre Singapore, head of the Department of Breast and Gynecological Cancer Division of the Radiation Oncology, also serving as the head of the Department of Central Informatics. Loon Sing Wong, senior radiation oncologist with 11 of the experience. Wee Swee Ong, a biostatistician with 7 years of experience. Ping Ping Pet, senior research associate at the Singapore General Hospital. And there are another 12 professional authors together. This dynamic team brings a view of the experience and knowledge to contribute to the body of the knowledge in their respective fields.
So first method was study design. This was a retrospective study conducted between January 2000 and December 2016, focusing on female Singapore residents diagnosed with breast cancer. The data for this study was extracted from the Singapore Health Service, encompassing 4 general hospitals and various national specialty centres, including the National Cancer Centre Singapore. Approximately 60% of all breast cancer patients treated in the public healthcare sector in Singapore are covered by this dataset. So, the data extracted from the patient information such as demography, disease details, treatment, and outcomes. Next is Housing Value Index, which is HI. So, Housing Value Index, how to estimate it? We estimate it using the residential housing value. They use a formula which was number of rooms in a flat times number of such flats per block divided by total number of units in a block. This resulted in the Housing Value Index, which categorized patients into 3 tiers. So, first is HI low with high subsidy. Next is HI medium with moderate subsidy. And lastly is HI high with minimal or no subsidy. The Housing Value Index table was included in the slide. Last but not least, treatment bill for all patients were examined from 6 months to 5 years after the cancer diagnosis. Payment made by Medifund were identified, leading to the classification of patients as ever received or never received Medifund support. It is important to note that this study was conducted with ethics approval, specifically a waiver of consent, CIRB 2019/2419, ensuring that ethical standards were maintained throughout the research process. Second method was outcomes. First is overall survival, OS, is defined as the time from diagnosis to death from all causes. It provides a comprehensive measure of survival considering all potential factors impacting the patients. Next is cancer-specific survival, which is CSS, represent the time from diagnosis until death, specifically from breast cancer. By focusing on breast cancer-related deaths, the metric offers insights into the effectiveness of interventions and treatments specific to the disease. Next is non-cancer specific survival, NCSS, measures the time from diagnosis until death from causes other than breast cancer. Importantly, NCSS were taken to being a competing risk events with the CSS. Furthermore, the survival outcomes were determined based on the patient status, which is for patients who remain alive, the survival outcome was determined by their last follow-up date, indicating the last contact with the health system. In the case of patients who died due to the disease, data was sourced from the Singapore Registry of Births and Deaths, providing accurate information about the date of death. By employing these survival measures and outcomes, the study aimed to paint a detailed picture of the breast cancer patient journey, considering both disease-specific and non-cancer-related factors. Last but not least is statistical methods. So patients' clinical pathology and treatment characteristics were summarized using frequency and percentage. So compare differences in characteristics between housing index HI strata. The chi-square test was employed, offering insights into the varied patient profiles across different housing categories. Follow-up time estimation was conducted using the reverse Kaplan-Meier method, allowing us to capture the duration of patient follow-up in our analysis. Survival estimates were calculated using the Kaplan-Meier method. To discern differences in survival between patient groups, the log rank test was applied for for overall survival OS, while grey test was utilized for cancer-specific survival and non-cancer-specific survival. It is important to note that timely surgery, a significant variable, was excluded from multivariable analysis due to concern about multicollinearity. This decision was influenced by the classification of all stage 4 patients as not needed under timely surgery. Addressing the challenge of missing data, regression models for overall survival and cancer-specific survival were conducted using variables with non-extensive missing data, namely age, race, stage, housing index, Medifund, and marital status. In terms of statistical significance, a two-sided p-value less than 0.05 was the threshold. All statistical analyses were performed using R software version 3.6.3, ensuring robust and standardized methodologies throughout the study.
The next part is the collected data in the result part. The study has an impressive sample size of 15,532 breast cancer patients who meet the selection criteria. Starting with the demographic data, the median age at diagnosis falls on 53.7 years old, which ranged from the 17 years old to 97 years old. The Chinese population was slightly overrepresented as compared to the actual national population distribution. The patients were categorized based on their housing value index. 66.6% of the patients classified as mid HI, followed by 27.4% of patients classified as a high HI, as well as 6.0% of them in the low HI. This division will become the fundamental factor through their statistics study below. Another important factor is the Medifund, a medical subsidy program. 50.8% of the patients receive Medifund. Among them, patients in the low HI are more likely to receive the Medifund compared to mid HI and high HI. Patients with a higher stage with a higher treatment burden were more likely to receive the Medifund. Furthermore, from the statistics, they found that patients with higher HI were more likely to have a lower stage of cancer at diagnosis. Patients with a low HI, on the other hand, were found to have a higher portion of advanced stage of cancer. Turning into the treatment landscape, the correlation between the socioeconomic status and the treatment decision emerged prominently. Patients with higher HI were more likely to undergo breast conserving surgery. Among those who had mastectomy, similarly, patients with higher HI were more likely to have a post-mastectomy reconstruction. Non-companion rate were highest for targeted therapy and chemotherapy. Patients in low HI are more likely to be non-companion to timely surgery and radiotherapy. However, the patients who receive Medifund were twice as likely to become companion with systematic therapy, especially targeted therapy. Patients were followed up for a median of 7.6 years. Observe that 5 years and 10 years survival were significantly better for patients with higher HI for each survival endpoint. Approximately 80% of deaths at 5 years were due to the breast cancer, which decreased about the 70% at 10 years. In the part of multivariable analysis, the study identified several prognostic factors including older age, higher cancer stage, higher tumor grade, estrogen receptor and progesterone receptor negative associated with a higher risk of death. They also face higher risk of death. In adjuvant setting, non-compliance to the treatment significantly increased the risk of death in patients who were not compliant to radiotherapy and targeted therapy.
In this study, they found evidence of disparities in both cancer and non-cancer survival of breast cancer patients in Singapore. Despite having easy access to high-quality care and increased financial assistance for the needy, breast cancer patients who live in lower-value housing had lower cancer-specific survival. Patients with lower housing value index presented with advanced cancer more frequently and had higher rates of treatment non-compliance, but Medifund subsidies increased compliance, particularly for targeted therapy. Furthermore, lower housing value index survival had higher non-cancer mortality, which combined with the existing higher cancer mortality to result in a nearly 15 reduction 10-year overall survival between patients at the extreme of HI status. Their findings were also consistent with previous local study that linked patients living in lower value housing to lower participation in health screening. A preference for alternative medicine and poorer health outcomes in psychiatric illness, chronic disease and head and neck cancer. Both were cited as a major concern in structured interviews with patients. Their research also found links between lower housing value index and surgery delays, as well as lower compliance with systemic treatment and radiotherapy, all of which are known to have negative impact on disease control. From the data shown earlier, the lower HI tire patients were also more likely to undergo mastectomy over breast conserving therapy and less likely to undergo breast reconstruction. Correlating with other study findings, they speculate that poorer patients may not be able to afford the work and family disruption caused by a lengthy course of adjuvant radiotherapy, as well as the cost of reconstructive surgery. Their findings show that it was treatment decisions and not strict disease characteristics that drove the observed differences in breast cancer survival. They speculate that other factors known to plague poorer patients, such as lower education, a lack of logistics, and transportation support to attend treatment, particularly radiotherapy and chemotherapy, a smaller family size, and a lack of social and psychological support, poorer nutrition, and life stresses may influence patients' choices. However, the study is limited by its retrospective nature, which may have left bias from unmeasured co-founder unaddressed. They underrepresented the more affluent population segment who prefer unsubsidized care from private providers by focusing on patients in the public healthcare system. The study also fails to assess quality of life, which is crucial in breast cancer, where survivorship is high and long-term prognosis is important. They may have missed the added subtlety and discrimination that a multidimensional socioeconomic status index may have in identifying vulnerable subgroups by using only housing value index as a differentiating factor for socioeconomic status. Despite the demonstrated association between socioeconomic and outcomes, this association may be indirect and the cause-effect relationship is not known with certainty. So the treatment criteria used in the study were chosen to be broadly reflective of practices for patients treated during the study. However, deviation from this criteria might occur due to the often nuanced, highly individualized recommendations made for each patient based on additional consideration of fitness, presence of comorbidities, and result of multi-gene genetic assays. Due to an earlier cohort that predated the availability of registry data, a significant portion of their study cohort had incomplete treatment information. Nonetheless, their study cohort, which included approximately 60% of all breast cancer diagnosed among Singaporean residents during the same period, combined with up-to-date mortality data from the National Registry, is likely to be an accurate representation of the country. Furthermore, their findings and implications are directly applicable to other countries with universal healthcare systems. The disparity in survival is likely to be even greater in countries with large income disparities and absence of universal healthcare. As the conclusion of this research, they discovered that socioeconomic status, as measured by housing value index, was associated with cancer-related and overall mortality. This effect was primarily caused by late disease presentation and poor adherence to treatment. They also demonstrated that increased subsidy improved treatment adherence and that Medifund recipients can achieve equitable cancer-specific survival. Targeted interventions to increase cancer awareness and screening access for low HI patients are urgently needed. Policy changes that extend employment, psychosocial, and economic support to the patient's family and carriers may increase compliance and improve survival. So, that's all from our presentation for this journal club, and thank you!